Hi guys, welcome to NUR 113 Family Health Concepts, and this is your safety lecture for Healthcare Module 1. We're going to talk about the concept of safety, national patient safety goals, anticipatory guidance, and safety across the lifespan. You'll find your learning outcomes listed on this slide, and they should be consistent with what's in your syllabus and what is in the book. So let's get started. So what is the concept of safety? When we think of being safe, we consider that we need to protect ourselves or someone against the occurrence of a risk, some kind of harm, injury, danger, or loss. So it can be all of those things. And in the healthcare field, especially as nurses, we are in a key position to keep people safe. We can do that through educating them. We can do that at the bedside in the clinical setting. There are lots of different ways that we can, excuse me, keep our clients and their families safe. So back in 1999, the Institute of Medicine came out with this report that talked about how terrible it was to go to the hospital because of all the safety issues people encountered. They talked about how many people died in hospital-related deaths just because of errors that could have been prevented. And this was a huge eye-opener to the nation in regards of mistakes and errors that can happen in the hospital setting or even outside of the hospital setting in other areas of healthcare. And it prompted this whole culture of safety movement to begin in healthcare. So you can see there that there was somewhere between 44,000 and 98,000 deaths in hospital errors. And Health Grades actually estimated that it was much greater than that at towards 195,000. And why the disparity in those numbers? And it's because things probably happen that go unreported. So when we talk about safety, we consider things such as errors and adverse events. So what is an error? Well, it depends exactly on what we're talking about. So if you think of medications, what is a medication error? Well, if you give somebody the wrong medication, then that is an error, correct? If you give them the wrong dose, that is an error. If you put someone on oxygen who's not supposed to be on oxygen, that is an error. So what distinguishes an error from an adverse event? Well, an adverse event is something that happens to someone that causes some kind of, that could potentially cause them harm, right? So also, the Institute of Medicine discovered that more than 50% of the errors that happen could have been actually prevented if there was some sort of system in place to catch those beforehand. So past this report, and even before this report, we have several agencies in the United States that help keep us safe, anywhere from the Food and Drug Administration all the way to the Department of Justice's ATF squads. We have Drug Enforcement Administrations. We have Joint Commission, right? American National Standards of Institute. Lots and lots and lots of agencies that just focus on safety. So in this course, we talk a lot about, or mostly about family, children, and maternity care. So in regards to safety, the hospitalized child is at a great risk for injury and error. We all know that children experience things much differently than adults do. So we have to be super extra careful with children in the hospital setting. They are susceptible to adverse pharmacologic events. Why? Because their systems are not as mature as an adult system, right? They have more how do you say it? They have more risk at for being allergic to something, right? They have not their immune systems aren't developed as well as an adult's immune system. They are still in developmental stages that make them susceptible. Um, Dosage calculations when you're giving meds is much different with children. You have to be very careful about what they weigh. So we have to make sure that we know how to administer safe doses, and it would behoove you to review safe dose for kids in ATI under your medication section. Also, the hospitalized child can come about whenever you have birth complications. So you have a mom who's had a delivery, and somehow during that delivery there was some type of complication that caused an issue um, for the newborn, and now it's hospitalized. So we think of things like shoulder dystocia, and you may not know what that is now, but that's okay. We'll talk about it later in this course. But basically, shoulder dystocia in delivery can cause babies to have a broken clavicle bone. Um, so those are types of birth complications that relate back to safety and how you care for patients in the hospital setting. Surgical errors, diagnostic errors, and risk for infection are all big ones for kids. Um, Children probably can't tell you where they're supposed to have surgery, correct? So who do we have to get involved? We have to get their caregivers involved in that process. Um, and because their immune systems are not developed as readily as mine and yours, they are at a greater risk for infection. And this little picture that you see right here is my daughter, Anna Kay, and she was hospitalized um, when she was almost 2 years old, 1.5, for actually H1N1. She had double pneumonia, and we had to put her in the hospital at New Hanover. And you can see her sitting there with her little bowl of cereal. This was the first day she had gotten to actually eat something because she had been NPO. You can see the little IV in her foot, but you can also see that little ankle bracelet down there on her right foot or left foot. Um, that is another safety measure that we put in place whenever we have children in the hospital, and that's to keep people from stealing them. It's like a little jailhouse bracelet. So what are some things that we can do to keep people safe? Well, we have things called National Patient Safety Initiatives, and what these do is they foster collaboration between these 4 agencies, okay? So healthcare facilities, the government, physicians and nurses, and clients. All of these people work together, all of these people and agencies work together to keep patients safe. And we do this through education, through better dissemination of safety practices, through resources, through risk management strategies. There are lots of different ways that these agencies and people work together to make sure that these national patient safety initiatives are met and carried through. So what do we need to make sure that these are successful? We need accurate data. And the Patient Safety and Quality Improvement Act helped to do that. So this is that government component helping us to keep patients safe. This act mandates a reporting system, and it protects individuals who report. So should you find an error in the hospital, you are obligated to report that, and you are also protected when you report that according to this act. So QSEN, you hear about this a lot in the hospital setting, and what is it? Well, back in the day, nursing education happened through apprenticeships. Nurses would go, if you decided you wanted to be a nurse, you went into the hospital, you found yourself someone that would allow you to be an apprentice under them, and you learned what you needed to learn. You didn't go to school. In the 1930s, nursing became a college-based career. So we started teaching people how to be nurses in a college setting so that they could broaden their horizons and expand their educational avenues. But whenever we did that, we unintentionally created a gap between education and practice. So when you did an apprenticeship, you were in the hospital, you had your hands in the fire, you were there doing things. But whenever we moved things to a college-based education system, we implemented clinicals, but you didn't get quite as much hands-on experience. So we created this unintentional gap. And QSEN was actually born to fix this gap consistently across all schools. This is where your nursing competencies come from. So all of those competencies that we check you off on whenever you're in clinical so that you get a satisfactory at midterm and a satisfactory at the final, that's part of this effort. So there are 6 of these core competencies with QSEN. They are patient-centered care, and this just basically means that clients are partners and they need to be included in their care. We can't just decide what to do for them. They have to have a part in that. Quality improvement. We have to monitor adverse events, because if we do not monitor them and we don't uncover them, then how can we improve safety for our patients? Evidence-based practice. We can't just always do the same old thing. We know that medicine changes daily, healthcare changes daily, and we have to stay abreast of the best practices and what is evidence-based so that we can take the best care of our patients. Teamwork and collaboration. Whenever you're in a hospital, you know how many interdisciplinary teams that there are that go into caring for just one person. We're talking things from nursing to lab to radiology to surgery to the physicians to the case managers to dietary. There are gobs of people who are involved in the care of one person in an inpatient setting. And it takes a lot of teamwork, collaboration, and effective communication to be able to provide that patient with safe care. Safety, knowledge sharing, and error reporting is a must if our goal is to keep our patients safe. And informatics. The more and more our healthcare becomes technologically based, it is imperative that nursing has an input into how informatics works in your day-to-day job at the bedside, because you are the one that's there, correct? So it's very important that nurses have an input. So here's you a little model, and all of these core competencies have each of them have a specific knowledge, skill, and attitude that go along with them. You can read about those in your book. But you can see that all of these columns are holding up the roof of this little house here. And if we can somehow move through all of these core competencies effectively in both the didactic part of your education and the clinical side of your education, then we can teach new nurses how to be safe as new graduates, and we can prevent patient harm or deaths. Excuse me. So what are some concepts that are related to safety? Well, there are oodles and oodles of them. Everything that you do in every area of nursing pretty much relates back to safety in one way or another. Clinical decision making is huge. That encompasses critical thinking, it encompasses clinical judgment, and it encompasses prioritizing care. Infection, um, just basics like hand hygiene and standard precautions for everybody are safety issues. Perioperative care, universal protocols at hospitals are a biggie here. So if this person's having this procedure, what is our universal protocol for this particular surgery? Um, Sterile field and hand hygiene when you're in the OR to prevent infection. Discharge planning and instructions. If you have somebody who is an outpatient coming in to get surgery, have we educated them well enough that they know how to take care of themselves when they get home, so that if they encounter some kind of adverse event once they get there, they know to report that back, or they know when to come back? And then quality improvement, and this can be something just as basic as the 6 rights of your medication administration, and making sure that those are followed every time at the bedside. So there are many, many, many concepts that relate back to safety. These are just a few. So what about national patient safety goals? Everybody has heard about national patient safety goals, and this should be a repeat for you. But these are put forth by the Joint Commission, and the Joint Commission is an agency that accredits healthcare organizations, and these goals are developed by a panel of professionals that have an expertise related to client safety issues. And the topics that they choose are chosen for a reason. They want them to have the maximum impact and usefulness and a minimal cost to healthcare facilities. So there are things that we can do that won't cost a whole lot, but that will have a huge impact on the patient population. So the purpose of these is to improve patient safety, and the focus are to figure out what the problems of healthcare safety are, and the action are to solve these problems. And so let's use an example of wrong site surgery here. Wrong site surgery is a national patient safety goal. That's 100% preventable thing. Doesn't take a whole lot of money to fix that problem. If you have patients mark the site that they are supposed to have surgery on, then we won't get to the OR, put them to sleep, and not remember what knee we're operating on, because the patient will have marked it for us. So that's just kind of a simple example. So here are the 2017 National Patient Safety Goals. The first one is identify patients correctly. We do that every time at the bedside with name and birthday. Simple, simple, simple. Improve staff communication. You know how whenever you get a lab result that is way out of whack and you have to call it to the doctor within a certain time frame? That is part of improving staff communication. What about using medicines safely? If we pull a medicine up at the Omnicell, if it's a multi-dose vial and we pull it up in a syringe, we're supposed to label that and put the dose on it. Otherwise, how do you really know what it is if you get busy? And then your 6 rights of med administration. Using alarms safely. This is a fairly new one. Joint Commission discovered that there were many places where patient alarms were being ignored and were causing Safety issues. So, for example, bed alarms. If your patient is on fall precautions and their bed alarm goes off, it's not to be ignored. Someone needs to stop by that room. It doesn't matter who it is, and each hospital will have their own protocols and how they handle this. Same thing with IV pump alarms. We don't just ignore those. When we hear them, we go check on them because if it's alarming, there is something not right. Preventing infection, hand hygiene, central line protocols fit in here. Identifying patient safety risks like falls and suicide. All those things should be identified on admission so that we don't miss anything, and patients should be continually reassessed every shift for new safety risks or potentially if they could come off of a safety risk. Preventing mistakes in surgery. We just talked about that one, marking your surgical site and also calling a timeout whenever you're in the OR. And here's just a list of those National Patient Safety Goals. And actually, these are the 2016 ones, but you can pull up the 2017 ones if you just Google those. They're pretty much the same. So what about community and local initiatives when it comes to the concept of safety? Well, if you click on this link, it will take you to the community health assessment for Columbus County. This is done every year by the health department here, and it will tell you in this report what areas Columbus County have that are safety issues, that are health-wise safety issues that need to be worked on. There's a North Carolina Baby Love Plus initiative that helps moms provide the correct care for their babies, to making sure that they're fed, making sure that they're caring for them appropriately once they go home. So that's another safety thing that happens. North Carolina Healthy Beginnings is also another program that's similar to that. And I tried to just list some that were local here that you could look into. So what about injury prevention in the clinical setting? The clinical setting is complicated. We got to coordinate care across multiple shifts. We got to coordinate care between multiple clients. And we also have to coordinate between multiple departments, like we talked about a few minutes earlier. Clients are a lot of the times very confused about what their treatment plans are. They're confused about how you talk to them about things. I'm sorry, guys, my throat is dry today. They're confused about how you talk to them about things, the medical terminology you used. Many of them don't understand it. So we have to be cognizant about what our patients understand, about their learning level, how they best learn. Also, despite our best intentions, many times adverse events and medical errors will occur anyway. And it can happen in many, many ways. So what we have to do is we have to report those and we have to learn from those. So what are some things that we see in regards to manifestations? Falls is one. And this is a way that one way we prevent injuries, right? We have to orient our clients. We have to make sure they're wearing their non-skid footwear. A lot of the times they have on those yellow gowns, those yellow socks. We got to be aware of the client's medical regimen, their side effects, their interactions. Got to make sure the room's well lit. There are 100 different ways we can help prevent falls in the clinical setting. And we all know that falls is one of the number one preventable injuries that happen in the healthcare setting and really outside of the healthcare setting. So that's why you see everybody gets a risk for falls. Restraints. Here's another big one. People can injure themselves in restraints. People have died in restraints. And this is one reason why restraints has become one of those red flags in healthcare in regards to safety. So we all should know what restraints are, and you should know that there are two types, physical and chemical. The purpose of restraints is to prevent your patient from injuring themselves or someone else, but they can cause injury and they can cause sentinel events. And you should be familiar with what a sentinel event is and a near miss. They are demeaning to your patients. They can be psychologically harmful. They limit your patient's autonomy. And you know, nursing is all about autonomy. We want the patient to be involved in their care. Do you think there is to make decisions regarding their care? And I can imagine there are not very many patients who would be agreeable to being put in restraints. The American Nurses Association has a position statement on this, and this is only an option when there is no other option. There are legal implications when you put people in restraints. You have to know your agency's policies. You got to know what CMS says. You have to know that your clients have the right to be free from those restraints if they are not medically necessary, and they cannot be used for staff convenience. So when we're talking about the CMS standards regarding restraints, you've got to have an order. If they're needed emergently, then your provider must be notified as soon as possible if your patient has been put in restraints for whatever reason. A standing order for a restraint as a PRN item is strictly prohibited. That cannot happen. If your doctor writes an order for a restraint PRN, you have to get him to rewrite that order because it is not allowed. And you got to have a new order every 24 hours. That patient has to be continually reassessed for their need for restraints. So how do we select one? We have to select them based on what's going to restrict their movement as little as possible. They can't interfere with the client's treatment. They have to be readily changeable. They have to be safe for that particular patient. And this is one we don't often think about, but they have to be least obvious to other people. So here are just a few types of physical restraints. We have the safety strap body restraint. There's a belt restraint, mitt or hand restraints, which you probably see mostly. And then limb restraints. Also, you'll see those in the ER a lot or in ICU. So another area where we can prevent injury, healthcare associated infections, 100% preventable. Catheter related bloodstream infections, healthcare associated pneumonia, surgical site infections, central line associated bloodstream infections, and C. diff associated infections. Every single one of those is 100% preventable if your hand hygiene, your standard precautions, and your healthcare protocols and policies and procedures are followed appropriately. And these are items that are tracked continuously by the healthcare organization that you will work for, and they're also tracked on a level even above that and then reported to the website that anyone can go to and look to see how many of each of these your facility has. And that helps them choose where to go for care. So, wrong site surgery. These things can happen due to inadequate client assessments and care planning, communication failures, an inadequate review of the medical record, multiple seizures on multiple parts in a single operation, failure to include the client and family when identifying the correct site, failure to clearly mark the correct site, and failure to recheck information before surgery. If a wrong site surgery occurs, that is a sentinel event. Medication errors. This should be something that you have had drilled into you since the beginning of NUR 111, the 6 rights of medication administration. So moving on to safety measures, what are these? These are activities and precautions that are taken to improve safety, and we've just talked about a lot of them. So examples of safety measures would be standard protocols and procedures at your particular facility, instruction materials, manuals, videos, educational trainings and demonstrations, assessing for risk factors, physical exams, and your assessment of a patient is a safety measure. And then root cause analysis and problem identification and solution can happen whenever there's some type of system failure where a safety measure isn't followed and there is a near miss, a sentinel event, or an adverse event. And a root cause analysis just means that you drill down on the problem that occurred and you keep asking yourself why it occurred. Why did that happen? And every time you come up with the answer to that question, you ask again, well, why did that happen? Until you can get to the very bottom rung of the ladder that perpetuated that problem. Anticipatory guidance. Anticipatory guidance is the preparation for some type of developmental or situational crisis that you were able to anticipate. It's a proactive based counseling technique, and it focuses on the needs of the individual developmentally. So at each stage in their life, what can they expect and what can they prepare for? How can we educate to keep them safe through anticipatory guidance? So for example, we provide information to that client based on their development or their behavior. So a specific example would be whenever a mother, a first-time mother, has a child in the hospital. One thing we educate them on before they go home is car seat safety, where an infant should be placed and how. It is an anticipatory guidance that it's a new mom. She may not be familiar with how to keep her newborn safe in the car. And also, motor vehicle accidents can be one of those areas in where newborns and infants can be gravely injured or die if they're not restrained properly. So we anticipate this is an area of education. We anticipate this is an area for this specific subpopulation of people that causes injury and death, and we educate on it. Safety across the lifespan. When we look at safety, we can't just look at everyone as a whole and anticipate what their needs are. We have to think of them in each of their stages of life. So we have specific safety concerns from even before people are conceived until they die. Categories aren't universal to all ages, and every age group has their own common injuries or illnesses. So we start with prenatal and infant risk for injury. Prenatal risks happen before a mother ever becomes pregnant, and a lot of the times they happen from maternal exposures from things such as the environment, her lifestyle. For example, maybe she's a smoker. We all know that's not good for anyone, but specifically prenatally. They could be genetic things that put her at prenatal risk. And then we get into perinatal risk, which means in and around the perinatal period. So when she's pregnant, she may receive poor prenatal care. Um, she may have poor maternal nutrition. She may be a smoker. She may be exposed to pollution or pathogens. Um, when we talk about perinatal risk, birth weight is actually the best predictor of survival and healthy development of a newborn. Um, so if we have a mom who can get appropriate prenatal care and we can track the growth of her baby throughout the prenatal period, we know that if we can get that baby to a decent weight, um, that it will have the best chance of survival and healthy development once it's born. So what about neonatal risk? There can be several things that cause injury for neonates. They can be congenital malformations, such as cleft lip or cleft palate. That could be included with deformations. Children can be born with extra fingers and extra toes. They can be born with congenital heart anomalies like ventral septal defect and chromosomal abnormalities like Down syndrome. Also, neonatal risks can be associated with disorders related to short gestation, preterm delivery, or low birth weight. And if you think about that, if a baby does not make it to full term, then the gestation period is shorter. The kid doesn't have as long of a time. And what do we weight? But we know that having a healthy birth weight is the best predictor of survival and healthy development for a newborn. Um, so a lot of the times your neonatal injuries or risks are a result of your prenatal risks and your perinatal risks or injuries. Infant risk. So we've all heard of SIDS, or sudden infant death syndrome. This is a big risk. It goes down dramatically once babies hit 6 months. But when new moms go home from the hospital, we really should educate them regarding sudden infant death syndrome, because this is a big area that can be prevented almost 100%. Suffocation, and that can happen when you have extra blankets in the crib, stuffed animals, and those things are areas of education definitely for new parents and even parents who are coming back over and over again. Falls, insect bites, and child abuse are also areas of infant risk. Infants are very susceptible to traumatic brain injuries from falls and child abuse. So we teach parents not to shake their babies because their brains are so small that the force of their brain kind of sloshing around in their skull can cause traumatic brain injury and can hinder their development or even cause death. And the same thing for falls. Infants don't have the knowledge or the developmental capacity to catch themselves when they fall, right? So if they roll off of a bed or roll off of a couch, they don't have the knowledge to brace themselves to not hit their head hard. Children and unintentional injuries. Toddlers. A very big unintentional injury regarding toddlers is falls. Burns, poisoning, drowning, shock, automobile accidents are all included as well. But falls is a big one. And if you look at this little picture up here, you can see my 2-year-old daughter, Anna Kay, standing on the roof with her dad. And just a quick story about her. She is my wild child. and we were spending a day at the lake, and I had put all the kids down for a nap, and she somehow snuck out of the back of the house while she was supposed to be napping, and I was in the kitchen, and I heard the back door slam, so I went out to look for her, and I could find her nowhere. Um, so I started freaking out because I thought she has fallen in the lake. I went running down the pier, but I couldn't see her anywhere. She wasn't answering me. Um, I ran to the front of the house and I couldn't see her there because I thought, oh my gosh, she's running to the road. Um, and then I hear my husband call me, and I come back to the back of the house, and here he is on the roof with my 2-year-old, who had proceeded to climb that ladder that you see in this picture. She walked out the back door, she saw the ladder leaned up against the house, and she just thought, I will go ahead and climb that and see what's up there. And she did. My husband was up there with his blower blowing pine straw off of the roof, because normally the ladder is not there. But that's how quickly injuries can be and how unintentional they can happen. So, can you imagine, had she fallen off of that roof, she could have been extremely hurt. Preschoolers, falls is another big thing for preschoolers. Um, they're just learning, they're moving fast, they like to run, they're not quite as coordinated. So falls is another big area for preschoolers that cause unintentional injuries. But also here, motor vehicle crashes, choking, poisoning, burns, drowning, and harm from people and animals. What do preschoolers like to do? They like to explore. They like to explore the environment around them. They also like to put things in their mouths. Um, they want to touch, if you have people walking by with pets, dogs and cats, they like to touch those things. They don't have a knowledge of how risky it can be or the appropriate way to sort of approach some of those situations. So they can be harmed from those types of things. And then car seat safety is big also for toddlers, preschoolers, and infants. So what about school age children? Well, school age children are at a developmental stage where they can play farther from home. They are less dependent on their parents, so they have a little less supervision than a toddler or preschooler might have. And they also move a lot faster on foot. So they are prone to falls and accidents and playground injuries. They're prone to being injured in motor vehicle crashes, fires, burns, and suffocation. um, you can see the little picture here of the boy who fell into the the gorilla cage at the zoo. I'm sure you guys remember seeing this on the news a couple of years ago. But this is an example of how quickly unintentional things can happen to school age children. The mom turned her back for just a second, and here her little boy did fall right over the railing into the gorilla pit. And what about adolescents? Well, adolescents are at a stage in life where they're trying to develop their own identities. They're separate and that's separate and apart from their parents. They are subject to peer pressure more so than school-aged children or any other age group. They also are beginning to get their driver's license. They're beginning to play contact sports, as you can see here in this football picture. So they are prone to vehicular accidents, especially when they start to get their driver's license, and recreational accidents due to sports injuries. They also are curious at this stage about firearms and substance abuse, and that's all part of that peer pressure. Um, peer pressure thing that happens at this stage. So with adolescents, especially in regards to sports, they are prone to head injuries, and those head injuries oftentimes go underreported or unreported for fear of not being allowed to play, for lack of education on the lasting effects of things like concussions, and also because of the tough it out attitudes that coaches, parents, and peers might have. So, this is a big area to do education on whenever we're talking about safety across the lifespan for people who come in contact with adolescents and to adolescents themselves. Um, because you more and more now in the news, you're starting to hear about the lasting effects of concussions and head injuries. Um, and this can be a big safety concern for this group. So, what about the nursing implications whenever we're talking about children and unintentional injuries? We've got to be aware of the risk factors. We have to make sure that our risks are unique to the client and their developmental stage. So there is your anticipatory guidance and where you start to bring that in um, to your nursing implication, assessment, and education. We have to include the client, family, caregivers, and significant others in our teaching, especially for children. It's not effective to teach a preschooler um, that it's not okay to climb a ladder to the roof because they don't care. They just see it and it looks like fun, so they do it. But it would be appropriate to teach the caregiver they should probably not have the ladder leaning up against the roof if their children are outside. Um, We want to reduce the risk for injury for all populations across the lifespan, so we have to be cognizant about where they are developmentally to be able to educate them appropriately to reduce that risk. And we want to increase the likelihood that these people will successfully implement what we teach them, or that we can successfully implement necessary measures ourselves. We have to provide awareness education to clients and parents, and we got to collaborate with the client about those specific risks and be able to individualize them based on developmental stages and lifestyles. We don't do a lot of talking about adults in this course, but I have included these slides here. So, just briefly, young adults are prone to poisonings, motor vehicle crashes, malignant cancer, suicide, homicide, and overexertion. Middle-aged adults, there again you see falls. And what about older adults? There again you see falls. Falls is in every single category pretty much across the lifespan. So you can see why it has become such a big deal in the hospital setting as well. So for your nursing assessment in regards to safety across the lifespan, what can we do? Well, we can identify indicators in our nursing history and our exam. We can use risk assessment tools, making sure that we are considering their developmental stage. We can evaluate their environment. We have to consider the client's culture because their culture will affect their lifestyle choices, and that's important because we're not going to change someone's culture. We have to be able to learn how to creatively navigate ways to help keep them safe or suggest ways to help keep them safe without disrupting their cultural beliefs. We need to acquire a complete client history. So that includes assessing past injuries and illnesses, reading into their medical records. And then we need to know the difference between modifiable and non-modifiable risk factors. It will not do us a whole lot of good to educate people about their genetics, right? Because we can't change their genetics. We can't change their age. Now we can educate them to let them know that those are things they can't change. So here are the things you can change. So modifiable risk factor examples would be things like smoking, not wearing your seatbelt, nutritional um, issues. Those are things they can change. Here are just a list of risk factors that I will allow you to read over on your own. Just try to think of some things that fit into each of these categories so you would have an idea of what they are. Diagnosis. So when we think about safety measures across the lifespan or safety in general, some diagnoses that you might see nursing-wise would be risk for injury, risk for trauma, risk for delayed development, or deficient knowledge. This little girl actually was in a golf cart accident, and she was riding with a friend, and her friend ran the golf cart into the ditch. And the golf cart turned over on top of her, and someone riding by actually saw this happen on the highway, and they stopped the car, got out, and was able to get the golf cart off of her, but her face was buried in the mud for a little bit, and you can see all of that petechiae on the back of her neck there, and kind of on her ear, but it was caused from restricted blood flow, and she was perfectly fine. She was kind of out of it to begin with, but she actually was perfectly fine. But here is just an example of another educational thing to, teach parents that it's probably not appropriate for certain age children to be driving golf carts without supervision. So what will we do planning wise whenever we're looking at these clients? We need to make sure that the clients can verbalize awareness of common safety hazards for their age group. Describe how to eliminate or minimize exposure to safety hazards. We want them to seek medical assistance when they're injured, report any drastic changes in health to a medical professional. And what can we do health promotion and risk management wise? Well, the biggest thing is prevention. Prevention, prevention, prevention. If we can prevent injuries and we can promote health, then we can keep people safe. Car seat safety and seatbelt use is a huge one. Just like I was talking about earlier with a new mom in the hospital, we need to teach her that her newborn or her infant is safest in the back seat, rear facing, preferably in the middle of the car. It's okay to be on one side or the other of the vehicle, but if you can place the car seat in the middle and rear facing, that is best. We want moms and dads of young children to know the poison control number. My children, I've had one kid eat an orchid. I've had Anna Kay eat about 50 Disney Princess gummies. So I think those were the only two times I've had to call poison control. But it happens to pretty much everybody who has young kids. How do we implement? We have to assess and screen for safety concerns. We got to provide that information on how to avoid, prevent, or treat hazards. And for children, we have to focus in on falls. And we're not going to prevent children from falling, but we can educate parents on how to lessen the injury from a fall. So, for example, don't place your infant on the bed and leave him unattended where he can roll off. Have your preschooler wear helmets, knee and elbow pads when they're learning to ride their bicycle. Take the ladders down from roofs whenever your husband is blowing pine straw off the top. Adolescents, they need to be educated about tobacco, alcohol, and illicit drugs because those are all things that that population seems to get involved in due to peer pressure a lot of the times. And there you can see with older adults, falls, medication side effects, and how do we try to implement safety in regards to those things? We educate. All groups are at risk for exposure to toxins, chemicals, lead, and substance abuse. So those are appropriate topics across the lifespan. It's a little learning activity. Um, so you can take a few minutes and pause this lecture and try to come up with some safety interventions for each of these age groups. And how do we evaluate that we have been successful? We have to recognize each individual's concerns and values. Some people will actively avoid hazards, and some will ignore the situation until it's actually an active problem. But if we are able to educate to the point that individuals recognize things they need to work on or avoid, then hopefully we have done a good job at trying to keep them safe. We need to educate them about wellness promotion, and we also have to respect their decisions regarding their lifestyle choices. So we can educate them about tobacco cessation, but if they want to continue to smoke, there's nothing really we can do about that. We have to respect their decision. What do we ultimately want our outcomes to be? We want to eliminate hazards. We want to reduce accidental deaths and injuries. We want to reduce economic loss from injury. So we want to make sure that adolescents and older adults, those populations actually will be able to continue to work, right, and provide for their families. Same thing for children. If you have a child who has a serious injury, it takes the mom and the dad out of work, and it creates huge financial burdens for families. We want increased awareness of factors that cause trauma or unintentional injury. And we want moms and dads and populations in general to be able to demonstrate correct use of safety equipment. So this is why in the hospital, whenever new parents are getting ready to be discharged to go home, that the nurses require them to demonstrate proper car seat safety use before we actually send them home. Communicating a hazard. To be able to communicate a hazard, you got to first be able to perceive it, right? You have to have a perception of it. You have to cognitively consider it. You have to be aware of it. You have to create an action against it, and your result hopefully will equal a positive outcome. I'm sure this is how my husband probably views the proper use of a car safety belt. All right, so let's talk about traumatic injuries in children, and then we'll be done with Healthcare Module 1. First and foremost, let's talk about assessment in relation to trauma. You got to remember kind of your ABCs, right? We want to assess respiratory status first, then cardiovascular status, then the nervous system, then we move on to musculoskeletal and integumentary. We want to assess those things that are going to kill us first. So here is just a little slide of an emergency trauma assessment: airway, breathing, circulation, disability, examine, temperature, get your vitals, a head to toe assessment, and then intervene. Head trauma. Whenever we have somebody come in with head trauma, especially children, we want an assessment of that. What caused it? Was it a fall? Does this patient have signs and symptoms of increased cranial pressure? Um, is there a change in level of consciousness? Is there a change in motor function? We want their vital signs. And then you can see in this little picture, here are some immediate warning signs after a head injury. So you might see these things in the first 24 hours. You might have a change in level of consciousness, increased drowsiness. Your patient might be confused. They're difficult to arouse. They may have seizures. You may see bleeding or water drainage from the nose or ears. That's an indication that something's not right inside there, correct? Pupils might be slow to react or they may be unequal. That's definitely a neurological sign. Your patient may have visual problems. They may not be able to see at all. They may have blurry vision. Um, they may see quote unquote stars. Um, they may have a loss of sensation to any of their extremities. We know if the brain swells in certain portions of the head, that it can cause different manifestations throughout the body. So it may be swollen in an area that causes you not to be able to feel your right hand. Your patient may have slurred speech, or they may have projectile vomiting. All of those are signs and symptoms of increased cranial pressure. How do we immediately manage these things? We want a CT or an MRI to determine what's going on in there. We want to do a neurovascular assessment, one that's complete and thorough, so that we have a baseline from where they came in to where we want them to head to, or so that we can know if they're getting worse or not. And we can decrease intracranial pressure by careful IV therapy of mannitol or dexamethasone. Skull fractures. These can be caused anywhere really around the skull, but you may see, if they're caused in certain spots, you may see orbital or post-auricular ecchymosis. So that means bruising around the eyes or behind the ears. You may see rhinorrhea or otorrhea, which means drainage from the ears or the nose. If it's clear, that's a huge concern. If you see clear drainage from someone who's had a skull fracture or a head injury and it's coming from their nose or from their ears, you should automatically think cerebral spinal fluid, which means they have a leakage somewhere in their head. It should be cultured, and if it's positive for glucose, then we can verify that it is indeed CSF. And if that is the case, these patients would be at an extreme risk for meningitis. So we would have to make sure that we take great precaution in preventing infection for these patients. And how do we manage people with skull fractures? We want to keep them in a semi-Fowler's position to drain the fluid, and they may possibly have to have cranial surgery to remove fragments that could be lodged in different places. They may have to have surgery to release any type of intracranial pressure that might be building up that we can't take care of otherwise. Subdural and epidural hematomas. You have to remember a little bit of anatomy about the skull and the brain to be able to get these two correct and not mixed up. So both of these are bleeding into the space between the dura and the arachnoid space. There is an aspiration of accumulated blood, and signs and symptoms of both of these can include increased ICP, head enlargement. Your patient can have seizures, vomiting, and increased irritability. If you look at these couple of pictures, the one on the left here is an epidural hematoma. You can see that it is above the dura. That is the meaning of epidural, right? So our hematoma is between the skull, and the dura. If it's subdural, then it is under the dura. So it is between the dura and the actual brain of your patient. Either way, it can cause increased cranial pressure. It can cause the brain to shift, and you can see any of these signs that we just talked about. Concussion. We talked about this just a little bit when we talked about safety considerations across the lifespan in regards to adolescence, because what do we say about adolescents? They are in that stage of life where they're in getting their driver license. They are playing contact sports, football specifically, baseball, and they are at great risk for concussion. So what is a concussion? Well, it is a mild traumatic brain injury that interferes with the normal function of the brain. Signs of concussions can include loss of consciousness, disorientation, incoherent speech, confusion, memory loss. They can have a dazed or a vacant kind of stare. And then if we head over to the symptoms column, they can have a headache or dizziness, difficulty concentrating, sensitivity to light, ringing in their ears. They can be very tired or fatigued, and they can have some vomiting. It's very important that with adolescents or with anybody that these are reported and followed, because we know that they can cause serious consequences later down the road in life. So nursing care for concussions includes the following. We need a neurovascular assessment that's thorough. We need vital signs. We need to decrease stimuli for these people. They need a break. These are not the people that need to tough it out and get back out on the field for another quarter in the football game. We need to promote rest. We need to take specific I's and O's for these people and give them IV fluids if they need it. Many times these people get sent home with just education about what to look for. So it's important that if you're the nurse doing that discharge education, that you're very thorough. Abdominal trauma. And when do we see abdominal trauma? A lot of the times we see abdominal trauma in children who've been abused, or we see it in people who've been in motor vehicle accidents. The biggest thing with abdominal trauma is it can cause hemorrhage, which results in shock, which, if not managed appropriately, can result in death. So how do we manage it? We do not give pain medication if somebody comes in with abdominal pain or trauma until we have a definitive diagnosis. If we give pain medication to someone who comes in with abdominal pain, then we can actually mask symptoms and we can cause a delay in treatment, which can ultimately cause a death. We want to suction and we want to test gastric contents if we need to. And what we test them for is blood. Because if we've had abdominal trauma, we are suspecting what? We suspect hemorrhage. So we want to test that gastric content for blood. These people may need NG tubes to suction blood out or to suction gastric contents. We might need a Foley to monitor their I's and O's strictly because of our worry about shock. And this picture just gives you kind of a general rundown of what anatomy is like in the abdomen regarding in the different quadrants. So you can review that on your own. Splenic rupture. We know that the spleen has a large holding capacity for blood, right? So if our spleen ruptures, we are at a really big risk for hemorrhage and shock. A lot of the times you see a splenic rupture when somebody's been in a car accident. This is part of an abdominal trauma. So these people have left upper quadrant pain, um, especially whenever they breathe in deep, and they have a positive car sign, which is pain that radiates to their left shoulder while they're lying down in supine position. These people, really the way to treat this is to have it removed in surgery. Liver rupture, severe abdominal pain on inspiration, and these people have obvious signs and symptoms of blood loss. So very similar to the splenic rupture. The pain may be a little more focused towards the right because that's where your liver is, but they just have severe pain. Um, and this can be extremely serious. These people can go into shock very quickly from blood loss. Here's one that happens to children quite often, dental trauma. This is a picture of my little Anna Kay. As you can see, she tends to be the one that I have stories about. But you can see her little tooth there is chipped off, and that was caused from a seesaw accident at daycare. And it cost me a whole lot of money at New Hanover to get that fixed. So what causes dental trauma? Falls and blows to the face. Luckily, her whole tooth did not fall out or was not severely chipped, but the nerve actually was exposed behind that tooth that was chipped, and so she had to actually have it removed and had a fake tooth put in there. She calls it her yellow tooth because it is a little slightly different color than the rest of her teeth. So she had to have a yellow tooth put in. But if this happens to a child, then what can we do? Well, immediately we want to wash the tooth in some salt water and store it in milk or a salt solution, and then get that kid to the ER. Sometimes they can be reimplanted. What is a complication from dental trauma? Well, obviously, if you knock a tooth out or knock part of a tooth off, you could potentially aspirate that injured tooth, and that can cause lung damage. So that would be a potential complication. And then also, even more obvious than that, malalignment of future teeth. So what about drowning? If you can remember back to our safety considerations across the lifespan, drowning was listed in pretty much all of those for children. People can drown anywhere. People can drown in about 2 inches of water. So bathtubs, pools, fresh and salt water. And the cause of death from drowning is when water fills the alveoli and it causes them to collapse, which leads to respiratory failure and cardiac arrest. Whenever you are taking care of a drowning victim who has been resuscitated and brought to the hospital, your priority focus has to be their respiratory function and exchange, right? Because if we have obstructed the alveoli, then we have obstructed our area for gas exchange. And if we can't exchange carbon dioxide and oxygen, then we're going to cause respiratory failures. So when you're caring for that resuscitated drowning victim, you have to focus on gas exchange and respiratory function. Another big one with kids, foreign body obstruction. This has also happened to me, but this one with my son, he stuck a rock up his nose one time and got it stuck there. We were luckily able to pull it out with some pliers. Probably not the smartest idea, but you know, if you're a nurse, you don't take your children to the hospital unless they are about to die. So we pulled it out with pliers. We actually still have that rock. My husband won't throw it away. So where can kids stick stuff? Well, they can stick stuff in their ears, in their nose, or in their throat. And if you don't know they stick it there, then what might you see? You might see some drainage coming from the ears or the nose, or you might have a foul smell that you can't figure out where it's coming from. You only know that when your kid comes up to give you a hug, they stink to the high heavens. Um, it's a serious challenge to be able to keep kids calm whenever you're trying to pull something out of an orifice that they have stuck it into. So if you're working in the ER and you ever get this experience, it is a great one. Sometimes they have to be sedated. Sometimes we have to wrap them in a sheet and sort of restrain them to be able to get things out. Um, for the ears, you can irrigate with normal saline if the tympanic membrane is not involved. If the tympanic membrane is involved, you can't really do that, and you have to seek help from an ear, nose, and throat doc. Last slide. I'd like for you guys to review box 51-3. It's about distracted driving, and there's your page number, 2713. I also want you to review ATI, doses for children based on their weight, and how to do safe dose for kids. And also review your foreign body airway obstruction and how to take care of that for people across the lifespan. So that's part of your basic CPR knowledge. And thank you for tuning in.